Good morning, everyone. The best case scenario is achieving type 1 big bubble, in which there is injection of the air and reaching the DOAS layer and doing brave slash exposing the DOAS layer and doing stromal excision and dissection without any perforation. However, what if type 2 big bubble is formed? Here's a case of a 34 years old female patient that having keratoconus with apical opacity, and we did partial terrafination, 80% of the thickness of the cornea at the intended site of terrafination, and we started to do a deeper dissection using crescent knife and going with the spatula. We can here notice that there is sudden release of resistance. So we are in a deep layer. And then with the cannula, we are starting to injecting our air. However, the just emphysema and the air passed into the AC. So I injected air in the AC again to guide me, and started again to do air bubble and just emphysema without bubble formation. So I did superficial keratectomy, and again I tried air injection at a deeper level, and we can notice that the big bubble is formed. However, I suspected that this is type 2 big bubble, so I decided not to open this and de-roof this air bubble and starting mechanical dissection. Guided by the emphysema that's present in the stromal layers, I started my dissection using blunt-tipped cannula and de-roofing over this blunt spatula and getting my way. Starting this dissection, while doing this dissection and doing the dissection bluntly at the periphery in order not to perforate and to keep the DOAS layer as much as we can. You can find the reflection of the air between the DOAS layer and the Descemet's membrane. It will appear much better in that side. Here I reached the DOAS layer, and I found this plane of dissection, in which the dissection went very easily, and I got the plane of DOAS layer, and I started to remove the remnants of the stroma. However, I faced with the presence of air beneath the DOAS layer, so I have to deflate this air. I deflated it. After removal of the remnants of the stroma, I deflated it using super plate at the periphery. We can notice the reflection of the air between the DOAS layer and the Descemet's layer. I deflated the air and the periphery, and unfortunately the AC is opened. However, I still have intact DOAS layer all over with the removal of the stroma. So just be calm and inject air in the AC and take your sutures. And this is the appearance of the patient at the end of the second day post-operatively. In 2019, there was a paper published in the Cornea Journal about the management of type 2 big bubble, and when we are going to de-roof type 2 big bubble, there is high incidence of rupture of the Descemet's membrane. والحقيقة 75% من their cases converted to PKB, so they adopted mechanical dissection when diagnosing type 2 big bubble. Go for mechanical dissection and preserve the DOAS layer. So the take-home message in eyes with type 2 big bubble, decimate membrane bearing technique, deroofing of the type 2 big bubble should be avoided, and instead going for mechanical dissection to clear the duous layer is more safe and reliable. الحقيقة my mistake إن هم كانوا بيعملوا deflation insulin syringe at the periphery. I did the deflation using very large super plate. So I opened the posterior the anterior chamber, and even with the opening of the anterior chamber, the presence of the duous layer acts as a guide, safeguard to continue the cases as a DALK procedure and not to convert into PKB. Also, there was an incidence يعني في البيبر اللي هم نشروها دي انه في double AC formation even when bearing the decimus membrane, even if there is no rupture for the decimus membrane. So the take-home message is we should, as much as we can, keeping the duous layer to help to complete your DALK safely. Thank you.